Hi, I'm Dr. Neil Barshis. I'm a vascular surgeon in Houston, Texas at Baylor College of Medicine. I just did a brief talk about how to improve your first sentence, your lead-off sentence when you're giving a patient presentation. Now I'm going to talk about pretty much everything else that goes into the history part of the presentation. The history, the exam findings, labs, and other testing. How to summarize that and how to package it all together. So what follows the first sentence? With both of the strategies I talked about last time, where you're either stating what you think is the problem and proposing a plan, or you're just stating what the chief complaint is. With both of those strategies, after you give that first sentence, you should spend some time talking about the history of the present illness. It seems obvious. I'm sure you learned in medical school that after chief complaint, the HPI is the next part. But you might be surprised at how often people go straight from first sentence to imaging findings, or other parts of the presentation. Talk about the symptoms. For almost everything, symptoms and history can be really important to go through. So here's what I recommend. To do that effectively, you start chronologically, beginning with when the patient first noticed relevant symptoms. If you need to, use the old cards or some other mnemonic to help you remember what's relevant, like associated things. For pain, what does it radiate? What instigates the pain? What relieves the pain? What's the location? What's the quality? What's the character of it? There too, these details, it continues to surprise me how often people don't mention that, or sometimes don't even collect that information when gathering data for a history. So in the history part, do stick with the history and do stick with what the patient told you, but at the same time, it is legitimate to go through any prior testing or any prior procedures that have been done and that the patient tells you about, things that were done at another hospital, things that were done a long time ago at your hospital, and that's history. That is relevant here. And it can be good to make that part of the chronology, or to at least discuss it after you talk about the chronology of the symptoms, if you think that is better for a given situation. You probably also know from medical school that what a patient does report is important, as well as what a patient doesn't report, things that are negative, things that are absent. So do talk about these, specifically state certain things, because it tells the other person that you know that a particular thing is important. You solicited information from the patient on that, and you found it to be negative or absent. Do make mention of pertinent negatives. After you do the history of the present illness, then you do a rundown of the patient's comorbidities. As I mentioned in the previous video, you probably should have already stated any game changer problems or any other very important or crucial comorbidities that are important that affect the interpretation of the primary problem. Here's where you would flesh them out a bit, starting with the ones that are most relevant. I gave an example of a woman with symptomatic carotid stenosis and a brain cancer. If you're presenting a patient like that, after the first sentence, you might talk about the TIA, you might talk about prior imaging, and then the next thing after that might be the glioblastoma, the brain cancer, and then getting into any other comorbidities that are present after that. You're kind of ordering it based on relevance and importance, weight overall. If you are in a time-constrained situation, you're presenting, it's an urgent patient that you need to present, and you're presenting to somebody who's mid-operation and can partially focus, and you just need to balance how much detail you go into, or whether you're even going to list comorbidities at that time at all. So, there can be times where if it's a really time compressed presentation, you just leave them out completely from that presentation and then discuss them later. But in general, just use your judgment on what to include and how much detail to go into. I can tell you that overall, what I'm listening for in this section is a couple things. Well, what I'm not listening for is I'm not listening to the list of comorbidities in order to try to solve those problems. The hypertension, the hyperlipidemia, obstructive sleep apnea. I'm not going to solve those problems. First of all, it's not my forte. Second of all, if there's something else that's more important, we're going to focus on that for now. Really, what I'm listening to is I'm listening for a couple things. One, do we need to do anything to safely manage the comorbidities in the perioperative period? And second of all, can we do anything to limit any kind of negative effects that comorbidity may have on the outcomes of an operation? Those two main things. So if you're talking about a comorbidity, some details that help inform those two questions, that's really most relevant. After the past medical history, past surgical history, do list relevant medications. We as surgeons, a lot of times we totally forget to do this, but just like comorbidities, a lot of medications need to be managed, especially in the perioperative period. So list at least relevant medications. Then discuss your exam findings. Do this. I think most surgical trainees are pretty good at this. The one thing that I would stress here is doing it without pointing to parts of your own anatomy. You don't have to point to your leg, you don't have to point to your abdomen, particular quadrants in your abdomen. You paid a lot to learn new words at medical school. Here's the opportunity to use them. Just describe the location, describe the appearance, use words to do that. And then summarize relevant labs and test results. Here too, I would stress summarize and relevant. For example, why are we discussing results for both legs if everything up to this point in time has focused on the left leg? There's no need to talk about it just simply because it's a result. You're not obligated to include it in the presentation. If testing does identify an incidental problem that does need to be managed, then sure, include it as another point in the problem list. But otherwise, leave it out so that you don't come across as being, make it looking like you're not sure what's relevant and you're just putting everything in there just to be safe. So then finally, wrap everything up with a summary statement and a bullet point type plan for management. For example, this is a woman who has a left forefoot abscess. I think we should admit her to the step down unit for an insulin drip for the hyperglycemia. We're going to give her a dose of vancomycin, renally dosed, bullet point type plan that it's kind of linked to the things that you've talked about so far. The other things that need to be managed, the other comorbidities, the other aspects of the current problem that need to be managed. Next, we're going to talk about the most common errors or problems that people have with presenting. And hopefully you'll find all this information helpful. All right, thanks.